Good morning. It's a privilege to stand here before you today to introduce you our Mason lecturer. Dr. Ed Sauter serves as the medical and program officer in the Breast and Gynecologic Cancer Research Group. He received his medical degree from Louisiana State University in New Orleans, Louisiana, and his doctorate of philosophy degree from the University of Pennsylvania in Philadelphia. He completed a residency in general surgery at the Ochsner Hospital and Clinics in New Orleans and a fellowship in surgical oncology at Fox Chase Cancer Center in Philadelphia as well. He also received a master's degree in health administration from the University of Missouri-Columbia, and he spent 20+ years in academic medicine as a physician scientist with an NIH-funded laboratory before joining BGCRG. The focus of his clinical care has been on the treatment of breast cancer, but his research has centered on the prevention and early detection of breast cancer and using non-invasive and minimally invasive approaches, as well as pregnancy-associated breast cancer. But he is equally passionate around seeing risk reduction from the disease of obesity for obesity-related malignancies. And so it is my pleasure to introduce you our Mason lecturer, Dr. Ed Sauter.
Well, hey, good morning, everybody. I hope you guys are up and awake and had a good night's sleep, and hopefully what I have to say will be of some interest to you. And, you know, Shanu's absolutely right. I'm going to go off script here for a second. I hope that's okay. And tell you very briefly about why I'm here. Obviously, it's because of him and you. I was at the University of Missouri in the Department of Surgery. I'm a surgical oncologist, as Shanu mentioned, and cancer prevention is a big deal for me. I'm in the Division of Cancer Prevention after all, and I was noticing that in our obesity group, our obesity surgeons were operating on women. They would lose weight, and you know, I was wondering if that affected cancer risk, and we didn't know the answer to that, of course. So I did a study with two of our bariatric surgeons and found that these biomarkers in breast fluid, because of breast cancer, dramatically improved. Dramatically. We published a few papers on that, and 10 years later, here we are. And we have the JAMA publication from this week. Dr. Ali, Dr. Schauer, other people probably in this audience. Congratulations. And we'll talk some more about all that. So I'll get back on script now. So I have nothing to report in terms of disclosures, and we'll talk about 3 areas. And by the way, so I work for the National Cancer Institute, and one of the reasons I pitched to Shanu, I pitched not to give a talk, but I pitched your interest in studying why or how bariatric surgery impacts cancer risk. And so that's what I would like you guys, at least some guys and gals, to investigate. How does cancer risk impacted by bariatric surgery? Because it is, and we'll go over the reasons for that. And Jamshed over here just reminded me in his patients, and probably yours too, that he sees a lot of his morbidly obese patients who are found to have endometrial cancer. And in fact, when you do biopsies of the endometrium in morbidly obese women, studies have shown almost half of them have precancerous changes, which go away once they lose a lot of weight. So clearly there's a lot of opportunities here. And so in terms of the cancer screening, I wonder if you guys and gals are, when you see your patients prior to undergoing surgery, what kind of cancer screening they've done. Are they up to date on all their cancer screening? And if not, probably they should be screened. So, impact of obesity on cancer, the NCI response, and the impact of bariatric surgery on health, including cancer risk. If I can get this to advance. Could you advance a slide, please? So there are 13 cancers that definitely impact cancer risk, obesity does, and prostate cancer, the mortality is higher. We know that obesity is going to soon surpass tobacco smoking as a leading preventable cause of cancer. And as you know, bariatric surgery demonstrates the most convincing evidence that weight loss leads to reduction, not only in risk, but also in mortality. So I'm just going to highlight a few of those and again reiterate endometrial cancer. An understudied cancer, and my group, the group I'm in, is breast and GYN, and endometrial cancer is understudied. What causes it, what prevents it, and what prevents it is not becoming obese. Esophageal adenocarcinoma, what's it caused by? Primarily reflux esophagitis, again related to obesity, and gastric cardia. It's just the other side of the intestine. Kidney cancer, same thing. Hepatocellular carcinoma, we'll talk about that, but it's NAFLD, non-alcoholic fatty liver disease, and on it goes. So, does losing weight lower the risk of cancer? We're talking about lifestyle changes, which is what most of these studies have been conducted in previously. And first of all, there was a large study of postmenopausal women where there was intentional weight loss of greater than 5%, and it did decrease the risk of obesity-related cancers, but unintentional weight loss did not decrease cancer risk. But a second study, Women's Health Initiative study, also very large, found that women who were obese, weight change did not alter their breast cancer risk. My point is that lifestyle changes have not convincingly confirmed that weight loss reduces cancer risk. And why is this? Probably related to how much weight was lost. So, we're going to talk very briefly. I don't want to get down into the weeds too much on you, genes and regulations and all the rest of that, but a little bit. So, obesity and overweight, what are the abnormalities? Well, two of the big ones, or three of the big ones, are insulin resistance. That drives all sorts of things like insulin-like growth factor, the binding protein, its receptors, adiponectin and leptin. It increases glucose levels, and of course there's hyperinsulinemia and chronic inflammation. And there's a lot more that needs to be studied about the impact of race and ethnicity. We'll talk about that a little bit, as well as socioeconomic factors and other modulating factors, and possible interventions like surgery. Metformin, by the way, was recently studied. It wasn't found to dramatically impact cancer risk. That just was published. So, what has the NIH done? Well, there's the Common Fund. I don't know if you guys have heard about the All of Us research program, over 1 million people that the NIH is recruiting. They want to study them from early in life for 20 plus years and see what impacts their life, their health during their life. So far we spent $170 million of your dollars, and we're going to spend more. So get involved. So far there are research coordinating centers, clinical centers, all these other centers. I won't read them all to you, but there's a dietary assessment center. So we want to understand how nutrition impacts health. Some of these other plans for nutrition research, there's the Nutrition Equity for All initiative to reduce health disparities related to diet. There's the prevention research for human milk, in other words, understanding how human milk impacts disease and development. There's the assessing determinants of malnutrition and its implications for treatment, and meal timing, including time-restricted eating, which is dear to my heart. We have a separate initiative. I will talk at another session, not this one, about time-restricted eating, which I don't know how many of you practice. I practice it. I believe it. I can't prove it works, but I believe it works. And we're spending money to figure out if it works. So, I'm part of the Obesity and Cancer Working Group. We're now talking specifically about the National Cancer Institute. We develop funding opportunities and administrative supplements. We summarize state of the science and determine critical research topic areas and prioritize them. And I'm going to talk to you about a couple of those funding opportunities at this talk. So we have 6 working groups. I'm on a few of them, but I help lead 2 of them, including prevention etiology and time-restricted eating. But I mean, the point is how obesity impacts cancer risk, and you can see these others. So we're really now focused. The NCI has had a real redirection to focus on how obesity impacts cancer, because we know it's going to be the leading preventable cause of cancer any day. So, the provocative question 2, that funding just ended. We gave out the money. The research is ongoing, but the question was, how does intermittent fasting, by the way, time-restricted eating is a form of intermittent fasting. Anything other than daily caloric restriction is intermittent. Affect cancer incidence. Some really great grants have been funded. We'll see what they find. There's a Center of Excellence to measure diet, physical activity, and sleep behaviors. Those grants were just funded. So how does physical activity interact with diet to impact cancer risk? We don't know. What's the independent and codependent interactions? We have a request for funding applications, 21031, and that's a further study on exercise and nutrition, and CA 21021, which is about how obesity specifically causes metabolic dysregulation and how that impacts cancer risk. And we're going to ask our bosses to give some money out to 5 grants next month to the tune of about $20 million. So we're spending money on this, and we're hoping you guys can help us understand it. Not only what it causes it, in other words, obesity-driven cancer, but how to prevent it. So, the data shows that bariatric surgery is better than lifestyle in morbidly obese subjects. You know this better than me probably. Bariatric surgery numbers have been increasing at least through 2019. My understanding is the pandemic maybe slowed those numbers down, at least transiently. I don't know. I'm not a bariatric surgeon. I suspect they'll go up again. The data shows there's more initial and sustained weight loss in lifestyle. There's dramatic improvement or elimination of type 2 diabetes. The improvement in type 2 diabetes precedes significant weight loss. That's important. Why is that? Is it the surgery independent of the weight loss? Is it only the weight loss? And if it isn't, what else is there? Do you guys have an answer? I'm not asking for an answer. But is there an answer? I bet there is. You know, at the NCI, we're all about mechanism. Why something happens, not just that it does. Phenomenology is not good enough for us. We want to know why. So reductions in cardiovascular risk, and then it reduces the risk of certain obesity-related cancers, although the mechanisms are mostly speculative. So do bariatric surgery procedures provide equal benefit? That's the other question. And generally, the data, as I understand it, shows that there's greater benefit from the bypass than there is from the sleeve. Yet the sleeve, the numbers are increasing, and the gastric bypass numbers are relatively percentage-wise decreasing. So maybe it's easier, maybe there's less complications. I'm not a bariatric surgery, but the data, as I understand it, shows that at least in the long term, the Roux-Y provides greater benefit, and possibly also in cancer. So the NIH has been involved with bariatric surgery at least from 1978, so it's not new, but especially in the National Institute of Digestive Diseases, Diabetes and Kidney, and Heart and Lung, both had these consensus conferences and got bariatric surgery surgeons involved, made recommendations on when you should do bariatric surgery. They established the labs study. There's been 3 lab studies now, the longitudinal assessment of bariatric surgery. The NIH funded that work, and now finally the NCI has come to the table. We have a plan and budget proposal saying we want to uncover the biology at the intersection of obesity and cancer, so we're all in, okay? We're all in. The labs, as I said, NIDDK finally established labs in 2002, 3 study phases, and then teen labs. It's still ongoing, the follow-up. And they've studied primarily the effect on diabetes as well as psychosocial characteristics, patient post-op use of healthcare services, and so on. But there's been some sidebar studies related to cancer, but not very much. So I want to pitch for you briefly PCORI, Patient-Centered Outcomes Research Institute. Some of you may be familiar with that. Some of you may even participate in PCORI. PCORI is an opportunity independent of NIH for you guys to get involved in bariatric surgery research. And I hope that you'll consider contacting your colleagues who work in PCORI to participate. So it's funded not by the NIH, it's funded by the Patient-Centered Outcome Research Trust Fund, which was authorized back in 2010, and now there's an amendment. And it gets money from two funding sources, from the Treasury of our federal government and a fee assessed on insurance plans, okay? So we're trying to get the insurance providers to actually come up with some cash to help understand how things work. And there is a section of PCORI related to bariatric surgery. So this is a curated data set of 66 million patients, 66 million. The great research team, streamlined processes, it's patient-partnered. And so this is just one example of a bariatric surgery study that was published. They studied the three most common procedures, looked at how each procedure compared to the other over 1, 3, and 5 years, weight loss and regain, improvement in diabetes risk, adverse events. And why did they think it was important? Well, as you know, surgery's increased, sleeve has increased in its use, despite a lack of data, at least at the time, comparing its effectiveness to other procedures. And it was published in the Annals of Internal Medicine, which is actually a great peer-reviewed journal. And here's their data. The good news is that patients maintain their weight loss over at least 5 years with both the band, the sleeve, and the gastric bypass. But the gastric bypass had the greatest weight loss, and it had the greatest maintenance of weight loss. So adjusted hazard ratios for diabetes remission, again. So the gastric bypass was 10% better than the sleeve in maintaining diabetes remission. It was twice as good as the band, and the sleeve was almost twice as good as the band, 1.85% anyway, 185%. And the gastric bypass patients had a lower relapse rate of diabetes than sleeve. So again, showing that at least in their study, that the bypass was better than the sleeve. So, if you have any interest in working with PCORnet, just some things in talking to some of the people on the board, they're interested in having more people work with them, but it's a mean for facilitating collaborations. It's not to basically say, give me a data set so I can study what you've already collected for me. That's not, it's a shared experience, it's a shared working. But you can propose ideas and studies. So I'm going to shift topics now, and I'm not going to go into great detail about the impact of various studies on cancer risk because Dan Schauer will talk about that tomorrow. But I did think it's important briefly to talk about some of the studies I think are important. I don't have the one from JAMA that was recently published, by the way, because the slides I prepared a long time ago. But anyway, probably the best study is the Swedish obesity study. That's the first one. It's the only, to my knowledge, prospective study. It's been going on now for almost 30 years. And it showed basically, and they published multiple studies showing that bariatric surgery compared to control prospectively decreased both cancer incidence and mortality. A second study showed there was a dramatic reduction in cancer incidence. And I'm not going to read all the results here, but if you go over to the right there under cancer effect, there's something notable. Under women versus men, females is the second to last column and males is the last column, the impact of bariatric surgery is dramatically better in women than men. Why is that? Okay, why is that? I mean, I have my own ideas, which I'm not going to express right now, but we need to understand why bariatric surgery is so much better at decreasing cancer risk in women than men. We do not definitively know why, and we should, if you're going to counsel your patients properly. Not only that, but there's some studies saying it increases colorectal cancer risk, twofold in some cases. So is that true? But not all studies confirm that. So again, you know, these are questions we need to counsel our patients. Suppose your patient is at high risk of colon cancer. Should they have bariatric surgery, for example? I don't think you have an answer for them. I don't have an answer for them. We need to understand whether it increases colorectal cancer risk. There's some theories about that, again, that I'm not going to go into right now, but investigating mechanisms is important. A little bit more about the Swedish obesity study here. Again, the only prospective study, long-term followed cohort. If you look there at the bar graphs in the left column there, surgery versus control, look how much better women did than men. It worked for both pre- and postmenopausal women, whether they had diabetes or not, whether their BMI was more or less than 40.6, younger and older, smoking or non-smoking. So, there was sustained lower incidence with a 33% reduction in cancer incidence. So what's this mechanistic link? We know that bariatric surgery on average reduces body weight, it reduces type 2 diabetes, it reduces metabolic syndrome, and it reduces cardiovascular risk. But we don't really know nearly as much about cancer. And is colorectal cancer risk increased? In several studies, as I mentioned, document an increase in risk, both in men and women, but at least 2 recent reports say that's not really true. So what's the difference? I mean, which study's right, which is wrong, or is it some of both? You know, especially if someone has a risk of polyps or a family history of colorectal cancer, should they be having bariatric surgery? And do race and gender matter? As I said, you know, many studies have said that the reduction in cancer risk is much greater in women than men. And the mechanisms to understand this have not been explained. And, you know, it might be related to the fact that the female cancers are hormonally driven and there's aromatase reduction with less fat, especially in postmenopausal women, so less endometrial cancer risk, less postmenopausal breast cancer risk. But I don't think that fully answers it. Some but not all studies of bariatric surgery show a significant decrease in prostate cancer. Some say it does, some say it doesn't. Again, what's the difference there? And part of the confounder is that about 80% of bariatric surgery patients are women. So if you're going to find power for a change, obviously you'll have 4 times as much power in the female population as male. And race, we know nothing, essentially, nothing. Is weight loss after bariatric surgery the only factor? Well, animal studies say no. Okay, so increased gluconeogenesis, which occurs with a Roux-Y gastric bypass, there's an initiation of this gut-brain-liver circuit inducing satiety and increasing insulin sensitivity. So that might be one of the reasons why Roux-Y works better than sleeve. And there's also increased energy expenditure at mice that undergo bariatric surgery. So maybe that's another reason why it's more than just the weight loss. So, chronic low-level inflammation, we know obesity causes that. It increases growth factors like IGF-1 that drives cancer. Fat cells produce adiponectin and hormones that stimulate it. Also aromatase, there's MAP signaling. I won't go into all of this, but suffice it to say there's a lot to understand, and we don't. What are the mechanisms besides weight loss that influence cancer risk? Is maximum weight loss or long-term weight loss more important? Is it more important in men than women? What about colorectal cancer? What cancers are favorably impacted? And does the procedure influence impact? So, now to the point where I want you to ask me questions at the end of this, please. I'd like you to anyway. We have these funding opportunities on the street. That means available now for you to get money from the federal government. I'm giving out, well, I'm not. The federal government is giving out money for excellent proposals. So we have program announcements for bigger grants, R01s, and smaller grants, R21s. And there's 3 receipt dates for 3 years. The R21 is for early stage projects, and the R01 is for larger, broader scope projects. And by the way, for the R01s, you have to have a bariatric surgery on the grant, or it's not fundable. So we want people in bariatric surgery to be part of the solution here. I'm telling you now, I got the NCI to do this, and we want bariatric surgery investigators, not only the surgeon, but the whole team, to be part of it. I mean, you probably may need a basic scientist to help you, and that's good. Get your colleagues to help you. What sort of studies can be performed? Preclinical studies, that means mouse studies or other animal studies. Human sample studies, many programs already collect biopsies and samples, or you can combine animal studies and human studies. I mentioned this before, so I'm not going to read all of this, but a few of these that I haven't mentioned I'm going to go over now. Do racial or ethnic background influence cancer impact of risk reduction? Does bariatric surgery affect the penetrance of high-risk genetic cancer predisposition? We don't know the answer to that. So, this is the review and receipt dates. If you look at the very left-hand column, and you can find this, the next receipt date is June the 5th. So hurry up and get, well, excuse me, not June the 5th, October the 5th. Hurry up and get writing. And if you don't get a fundable score, you can resubmit. So the last receipt date is June the 5th, 2024. So I hope that you will take from this talk that bariatric surgery does impact cancer risk, that the National Cancer Institute is very interested in understanding how and why, and that you will get involved. Thank you.